Hi, my name is Dr. Andrew Stein, and I'm an internal medicine resident at the University of Florida. I will be presenting a case report, high output heart failure in hereditary hemorrhagic telangiectasia and congenital absence of inferior vena cava. I want to thank both Dr. Christopher Perry and Dr. David Winchester in the UF Cardiology Department for their contributions. Hereditary hemorrhagic telangiectasia, or HHT, is a genetic disorder characterized by arteriovenous malformations, also known as AVMs, with a reported incidence of 1 in 10,000 in North America. High-output heart failure, or HOHF, is a rare complication of HHT precipitated by abnormal vascular flow. Unrelated, congenital agenesis of the inferior vena cava, AIVC, is a rare vascular anomaly with a reported incidence of 0.0005 to 1%. Both unique pathologic conditions are present in our patient. A 39-year-old G1P0 female at 29 weeks gestation with history of HHT and recurrent epistaxis and gastrointestinal bleeding in the setting of chronic intestinal AVMs was admitted from high-risk cardio-obstetrics clinic following a screening transthoracic echocardiogram suggestive of aortic dissection. Figure 1 demonstrates this imaging, with the color Doppler flow identified within the aorta and the suspicious false lumen segment just below it. Further imaging with cardiac MRI and aortogram, shown in figures 2 to 4, revealed congenital infra-hepatic AIVC with compensatory dilation of the hemiazygous and azygous veins. Figure 2 shows both the dilated azygous and hemiazygous veins running alongside the aorta. Figure 3 highlights the hemiazygous vein posterior to the aorta, and in Figure 4, the dilated azygous vein to the right of the aorta. 4 weeks later, our patient was readmitted for high-risk cesarean delivery. Her immediate postpartum period included recurrent epistaxis and GI bleed requiring blood transfusions, as well as anosarca treated with IV diuretics. She continued to experience progressive dyspnea and anosarca after discharge, prompting admission 2 weeks later. Admission labs were most notable for a 6.5 hemoglobin, 1.7 albumin with mild transaminitis and hyperbilirubinemia, and a 265 BNP. Hepatology evaluated the patient, and triphasic computed tomography of the liver showed hepatomegaly with severe intrahepatic arteriovenous shunting and ascites. Figure 5 highlights these extensive AVMs. Paracentesis with fluid analysis was consistent with cardiogenic ascites, and a transthoracic echocardiogram showed normal systolic function with grade 1 diastolic dysfunction and moderate pulmonary hypertension. Figure 6 demonstrates the elevated right-sided cardiac pressures measured by pulse wave Doppler. Cardiology was consulted due to concern for HOHF in the setting of severe intrahepatic shunting. Right heart catheterization revealed elevated biventricular filling pressures with postcapillary hypertension, cardiac output of 7.4 liters per minute, and cardiac index of 4.7 liters per minute per meter squared, confirming the diagnosis of HOHF. For both her recurrent hemorrhage and HOHF, she was started on bevacizumab, an anti-VEGF monoclonal antibody, and on discharge, outpatient infusions and follow-up with hepatology, cardiology, otolaryngology, and hematology were coordinated. As previously noted, the incidence of HHT is just 1 in 10,000 in North America. Epistaxis is the most common identified symptom, with GI bleeding less common. About 3/4 of patients have hepatic AVMs, of which only 8% are symptomatic, and HOHF being a severe uncommon complication. Our patient had several contributing factors to her heart failure. Hepatic AVMs reduce systemic vascular resistance and can grow in pregnancy, amplifying this effect. Other physiologic changes in pregnancy, such as increased cardiac output and intravascular volume, also contribute. It generally takes a few weeks for these abnormalities to return to baseline. The only current definitive therapy for HOHF and HHT is orthotopic liver transplantation. However, bevacizumab has been shown to be a well-tolerated and viable therapy. Congenital IVC abnormalities are usually asymptomatic, though have an increased risk for DVT. The rare complete or partial infra-hepatic AIVC results from failed anastomoses in week 6 to 8 of embryogenesis with subsequent development of collateral flow. This case presents a unique complex physiologic and anatomical challenge to diagnosis, highlighting the potential long-term benefit of bevacizumab in treating HHT and HOHF in a patient exhibiting a positive, durable response to therapy during serial follow-up. Thank you for listening.